lovely speakers. We have Wi-Fi access. If you need any information, we have it up here. And without further ado, I'm going to introduce our speakers. So first off, we have Dr. Valerie Arsenault. She has been working as a pediatric hematologist and oncologist at St. Justin since 2020. She's medical director of the blood bank and head of the transfusion medicine service at St. Justin. She's also an assistant professor at the University of Montreal. She's the president of the pediatric expert group of the Quebec Transfusion Medicine Network, and she also sits on the Committee Consultation National for Transfusion Medicine, and her research interests include neonatal, pediatric, and OB transfusion medicine, as well as medical education. And then we have Miss Josephine Fosua, who is a sickle cell warrior, and she's founder of Queen Afro Art, and she's been drawing since she could pick up a pen and paper. Diagnosed at a young age with sickle cell anemia, art became a part of her life that helped her get through stays at the hospital for sick children. She knows her art was given a voice, which is not seen or heard. Extended hospital stays and medical procedures have not deterred Josephine from lending her voice to sickle cell advocacy. Additionally, she showcases her art both locally and online. All right, so we'll have Dr. Arsenault start with her talk first.
Hi everyone. So thank you for the introduction, and thank you for the I want to thank the organizer for the invitation to present today. As you recognize, I have a little French accent. I hope you will understand me well during the talk. I'm very happy to present to you about alloimmunization and hyperhemolysis in sickle cell disease. I have nothing to disclose. So the objectives of the presentation are to understand pathophysiology, risk factors, and consequences of red cell alloimmunization in patients with sickle cell disease and the strategies to prevent them. To review also the epidemiology, pathophysiology, and clinical and laboratory features and treatment strategies of hyperhemolysis. So we'll start with a case. This is a 17-year-old girl with sickle cell disease, and she's on hydroxyurea. Her hemoglobin baseline is about 75. She is known for a splenectomy at the age of 5, a vascular necrosis of the femoral head. She also underwent an adenotoxalectomy, and she was prepared at that time with preoperative simple transfusion, and it went well. She is also known for a severe scoliosis, and she is waiting for surgery. She received a total of 25 red blood cell transfusions since birth, and she is known for an antibody against the big E. So unfortunately, she underwent a traumatic knee fracture, and she needed orthopedic surgery. Urgent orthopedic surgery. Her hemoglobin level was at 80, so they gave her 2 units of red blood cells. Her hemoglobin went up to 100, 110, and she had the surgery. Everything went well at first, and she went back home. But 2 weeks later, she presented again at the emergency department because she had severe abdominal pain, fever, and difficulty to breathe. So they found that she had an abdominal vaso-occlusive crisis with acute chest syndrome. Her hemoglobin level was at 52, so it was very low compared to post-transfusion. So it was pre-transfusion 80, post-transfusion 100, and back at 52 2 weeks after. She had a relative reticulocytopenia, so usually when you have a drop of the hemoglobin, we expect to have an increase of the reticulocyte count, but it was abnormally normal at 75. She had extremely high LDH at 3,700 and severe hyperbilirubinemia. She had also a low haptoglobin and a creatinine that was high at 164, so an acute kidney injury. So we suspected a hyperhemolytic syndrome. we did immunohematology workup at the blood bank, and it showed that she had a direct antiglobulin test that was negative at first, but it was retested a few days later, and we found that she had a positive Coombs testing for anti-WRA. So she was treated for her hyperhemolytic syndrome. First, I will talk about it, but we avoid transfusing these patients. And the mainstay of the treatment is to give immunomodulatory treatment with IVIG and prednisone. You want also to stimulate the erythropoiesis because there is reticulocytopenia, so we gave erythropoietin and folic acid. And she finally improved. So we'll quit the case and go back to the case at the end of the presentation. So as you know, red blood cell transfusion is really important to treat patients with sickle cell disease. It's a central intervention to prevent and treat many acute and chronic complications. It may be used to increase the hematocrit and the hemoglobin to improve the oxygen carrying capacity and decrease the symptoms of anemia. However, it can also be used to decrease endogenous production of red blood cells containing the hemoglobin S. So there are two broad strategies for the transfusion in sickle cell disease. The episodic strategy like for preoperative preparation or for treatment of acute complication. There is also a chronic strategy to lower the hemoglobin S level and prevent some complication like stroke or recurrent vaso-occlusive crisis. And usually you want to maintain an hemoglobin S below 30. In some patients, it's 50 that we want to have. It depends on the indication. Here are the major indications of red blood cell transfusion in sickle cell disease. So to treat the acute stroke or to prevent primary or secondary strokes. We use it also to prevent postoperative acute chest syndrome, to treat acute chest syndrome, and to treat also splenic sequestration. Even if transfusion is really, really important to treat patients with sickle cell disease, it is not without any risks. Some particular risk that you have to keep in mind for patients with sickle cell disease is alloimmunization and delayed hemolytic transfusion reaction, which are the topics of this presentation. Other particular risks that we see in these patients is the iron overload for the patients that are chronically transfused, and also hyperviscosity if the hemoglobin levels go above 110 to 120. So now, the red blood cell alloimmunization is the production of an antibody directed against other people's red blood cell. In fact, there are, everybody knows ABO blood group, but there are more than 40 different blood groups, and it comprises more than 400 different antigens, and depending on our genetic, we don't have the same combination of antigens on the red cell surface. So if you are exposed to an antigen that you don't have, you can develop an antibody against it, like you develop an antibody against viruses or other different things other than you. So it can happen due to the differences between the blood groups, between the donors and the recipient blood group. It increases the risk of hemolytic transfusion reaction, and it leads also to delays and difficulties in identifying compatible red blood cell units. I really like this graph because it shows how we produce antibody for the first time and how is the evolution over time. So as you can see, if you are exposed to a transfusion, your body can make the antibody for the first time. This process is called the primary alloimmunization, and it takes a couple of weeks. So it's a process that will go unnoticed, and it will not be accompanied by hemolysis. If you don't check the antibody screen to see if your patient if your patient developed an antibody after the transfusion, in like 1 to 2 months after the transfusion, you can miss it, in fact, because after that, the antibodies will go under, they will decrease. The level in the blood will decrease. This phenomenon is called the evanescence, and it can become below the detection limit of the test in the blood bank. So at that time, if the patient presents again, like in a year, in the emergency department and he needs blood transfusion, you will do the antibody screen and you will potentially miss the antibody because it's still there, but it's below the detection limit. And if you give another blood product that is positive for the corresponding antigen, it will bring back an anamnestic response that is very, very rapid, and the patient will, it will stimulate the production of the antibody, and it will attack the red cells that are transfused, and they will be destroyed, and it will do the hemolysis. So to summarize this graph, there is two different types of antibody reaction. So the delayed serologic transfusion reaction, which is the primary alloimmunization without hemolysis. And the prevalence in the sickle cell population is very high compared to the general population. So it's up to 35% of patients who receive blood that will develop antibody in the sickle cell population compared to 2 to 5 in the general population. The other type of reaction is the delayed hemolytic transfusion reaction. So that is a post-transfusion hemolysis due to red blood cell alloantibodies that occurs within the 21 days post-transfusion. It classically occurs after the re-exposure to a red blood cell antigen that the patient had previously been immunized against. The incidence is reported to be about 5 to 8%. However, it's probably underestimated because it can sometimes be misdiagnosed as vaso-occlusive crisis after transfusion if you don't check the antibody screen. And the range of severity can go from mild hemolysis to rare, potentially fatal hyperhemolytic syndrome. There are multiple factors that explain why the patient with sickle cell disease are more at risk of alloimmunization compared to the general population. So first, there is a recipient-donor red cell antigen mismatch. So as you know, patients with sickle cell disease are coming from Black ancestry, and the majority of blood donors, they are coming from Caucasian background. And there are disparities between the antigen, between these two populations. So the Black patients, they usually don't have some antigens of the red cell surface like KEL, big C, and big E. But the Caucasians, a big proportion of Caucasians, they carry these antigens on the red cell surface, so the big C, the big E, and the KEL. So if you give blood from mostly Caucasian to a Black patient, they will be exposed to antigens that they don't know, and they are more at risk to make antibodies. So this is why we at least prevent against Rh and KEL alloimmunization for all patients with sickle cell disease. A second thing is that in the Black population, there is Rh genetic diversity. So in the Caucasian population, most of the people are either D positive, so with the classical D on the red cell surface, or D negative, so they don't have it. But many patients in the Black population, they are positive for the D, but it's a D that is different than the classical D. It's what we call a variant. It's the same thing for the big C, the big E, and the little c and the little e. So because they are a bit different than the classical form, they are at risk of making an antibody if they are exposed to the classical form. So that contributes to the increased risk also. And finally, sickle cell disease is not just a disease of anemia, it's also a pro-inflammatory disease because chronic hemolysis of the own red cell of the patient will free heme and hemoglobin in the blood vessels, and this will stimulate the neutrophils and macrophage to produce pro-inflammatory cytokines. And these cytokines will stimulate the immune system, and this immune system will be more activated, and the immune system will want to produce antibody against things that are different than the patient, so red cells that are different, okay? So that contribute to the mechanism. Also, we well know that patients with sickle cell that are transfused during acute infection or acute chest syndrome, they are more at risk of developing antibody because they are more inflammatory than if they are transfused pre-operatively or chronically. There are different strategies to prevent alloimmunization in sickle cell. So first and foremost, you must ensure that transfusion is really necessary. And second, if you transfuse, you must at least, if the patient is not known for an antibody, you must at least match for RH and KL. And if the patient is known for one or more antibody, he is at risk of making many more antibodies. We call that the immune responder status. So you have to match more extensively. So you also match for Duffy-A, JK-A, JK-B, big S and little s. It's other antigens that are at risk of making antibody if you don't have these on your red cell surface. And finally, genotyping studies are really helpful because you can see if the patient has a variant of the D or the big E, big C, little c. And if he has a variant, the ideal would be to give blood that match with the variant. However, that is not always feasible because we lack blood from the Black community, and we cannot give the same exact molecular blood to all the patients. So at least you do it if the patient has developed an antibody. Now, I'll talk about hyperhemolysis. So hyperhemolysis is when the patient level of hemoglobin after transfusion is lower than before. And this is because there is a destruction of the transfused red blood cell and also of the own patient red blood cell by a bystander hemolysis. You can see or know antibody when you do the immunohematology testing at the blood bank during this hyperhemolysis episode. And the exact pathophysiology remains unclear, but there are multiple hypotheses. First, there is a complement activation through classical pathway, the antibody, or through alternate pathway, the free heme and hemoglobin that activate also the complement. And the complement activation results in membrane attack complex formation on the red cell surface, and this will destroy the red cell. And the destruction of the red cell will release intravascular free hemoglobin and free heme, and this will cause oxidative stress and nitric oxide reduction. The nitric oxide reduction will cause vasoconstriction, and this is why the patient with hyperhemolysis, they usually present with vaso-occlusive crisis or acute chest syndrome. There is also macrophage phagocytosis of red blood cell, either in the circulation or also in the bone marrow. They will engulf the erythroid precursors in the bone marrow, and this will cause the reticulocytopenia because it will prevent from making new red blood cell to compensate the destruction. Patients with hyperhemolysis, they present usually within the 7 next days following the transfusion, but it's up also to 21 days post-transfusion. Usually they will present with a recurrence or a new vaso-occlusive crisis or acute chest syndrome after a transfusion. And they will present usually with fever and also dark urine, which is due to hemoglobinuria. If you do the blood work, you will see that there is a rapid, unexpected hemoglobin decline to below the pre-transfusion level. Usually it's a drop of more than 25% of the level pre-transfusion. And you will have a significant decrease of the hemoglobin A. The hemoglobin A is coming from the transfused red cells that are destroyed. There is also severe hemolysis, so the parameter of the hemolysis will be very much altered. So there will be indirect hyperbilirubinemia. The LDH will be extremely high in hyperhemolysis, and there will be also hemoglobinemia due to intravascular destruction. There will be also acute kidney injury because of the too much hemolysis process. And also you can see a decreased reticulocyte count because of the suppression of the erythropoiesis. And when you are doing the immunohematology workup at the blood bank, you can have, in half of the cases, a positive direct antiglobulin test with a newly detected alloantibody, but in half other patients, you will not find that. Here are the criteria for the diagnosis of hyperhemolysis. It's a summary of what I just said. There are particularities regarding the diagnosis of hyperhemolysis. So first and foremost, you need to be very quick to recognize it, because it is important not to transfuse the patient again, even if the hemoglobin is very low, because this will exacerbate the hemolytic syndrome. And you need to initiate immunomodulatory treatment very quickly before irreversible multiple organ failure develops. You need also to eliminate alternative cause of severe acute anemia, because you don't treat them the same way. So examples of alternative causes include splenic sequestration, autoimmune hemolytic anemia, mistransfusion, or bleeding. Diagnosis of the hyperhemolysis is not dependent on evidence of newly formed antibodies. So like I said, up to 40% are associated with no identifiable antibodies. Why? Most of the time it's not because there is no antibody, it's just that the antibodies are below the detection limit, or because the brisk hemolysis will deplete the levels of antibody-coated red blood cells below the detection, and the DAT will be falsely negative. The other reason why we cannot detect the antibody all the time is that sometimes the antibody are against antigens that are not expressed on the screening or panel cells in the blood bank. So we'll not find the specificity of the antigen. Other mechanisms are also involved, like I said, the macrophage activation and phagocytosis of red blood cells. So sometimes it's not because there is antibody that we have the hyperhemolytic syndrome. Now I'll talk about the treatment. So there are some supportive measures that you have to do. So intravenous hydration, pain management, and also ventilatory support if your patient have acute chest syndrome. Regarding the transfusion management, like I said, you must refrain from giving blood transfusion again, even if the hemoglobin is very low, because you will just exacerbate the hemolytic syndrome. And you have, at the same time, to do what we call the patient blood management or blood sparing strategies. So you limit the unnecessary blood draws, laboratories, and you use very small tubes for testing. And if transfusion is unavoidable, you have to give phenotyping and genotyping matched red blood cells. Regarding the immunomodulatory therapies, so it's really the mainstay of the treatment in hyperhemolysis. The first line is corticosteroids and IVIG. The second line is eculizumab. You have also, you can use the rituximab if you plan to transfuse again, because it can help to decrease the risk of making new alloantibodies. And another treatment is the tocilizumab. I will talk more in details about these treatments in the next few slides. Also, because there is a suppression of erythropoiesis, you need to address that by giving erythropoietin, and also to make sure the patient have enough enough iron. So some patients, they are already in iron overload, so you don't need to give IV iron for them. But if they lack iron, you need to give some to make sure they have enough to create new red blood cells. You have also to give folate, and if they lack vitamin B12, you can give as well. So the American Society of Hematology 2020 guidelines says that you should avoid further transfusion as much as possible unless the patient is experiencing life-threatening anemia with ongoing hemolysis. And if transfusion is unavoidable, you need to give extended match red blood cells. You should consider transfusing the patient if the hemoglobin falls below 30 to 35, or at a higher level if signs of hypoperfusion in the patient. The ASH guidelines also suggest immunosuppressive therapy with IVIG, steroids, rituximab, and or eculizumab if the patient presents an hyperhemolytic syndrome. So regarding the first-line immunomodulatory therapy, it consists of corticosteroids and or IVIG. So usually we give both, but if it's a mild process, you can try just one or the other. Regarding the corticosteroid, just keep in mind that it can aggravate vaso-occlusive crisis. So it has to be in the balanced decision. Regarding IVIG, so it can, the potential side effects are hyperviscosity, thrombosis, hemolysis if the patient is non-group O, and also kidney toxicity. So if the patient has an acute kidney injury, you need maybe to adjust the dose. Now, regarding the eculizumab, so it's an antibody directed against the complement C5, so it prevents the cleavage of the C5 into C5a and C5b, and ultimately it prevents the formation of the complex, the attack complex, and the destruction of the red cell in the vessels. It has been described in some publications since 2015. It is used for patients that have or have not detectable antibodies. And you have to make sure the patient receives anti-meningococcal vaccination before receiving it. It's very expensive and sometimes it's difficult to access, so can be a barrier. Rituximab, so it is an anti-CD20 drug. So it targets the B cell that transform into plasma cells, and plasma cells, it's the cells that create antibodies. So it will prevent the formation of new alloantibodies. So it can be given more if you think transfusion is unavoidable. And the potential side effects are progressive multifocal leukoencephalopathy caused by JC virus reactivation and hepatitis B reactivation. Regarding the tocilizumab, so it's an antibody against the interleukin-6 receptor. So the tocilizumab will prevent macrophage response to this pro-inflammatory cytokine. It has been described in hyperhemolysis since 2019, and it is used either alone or following other immunosuppressive therapy. Like eculizumab, it is very expensive and it is difficult to access. Regarding the stimulation of erythropoiesis, so you use erythropoietin plus minus iron, folic acid, and vitamin B12, and you must hold hydroxyurea until cytopenia resolves. Here is a little summary of the treatment. So if we go back to the clinical case, 8 months later, the scoliosis repair surgery was planned. So scoliosis surgery is not an orthopedic surgery, and it has a moderate to severe risk of having vaso-occlusive crisis or acute chest syndrome after the surgery. So usually you need to do at least a manual partial exchange transfusion or an automatic partial exchange transfusion. We decided to do a manual because manual use less red blood cells, so less exposure. And we had to prepare because she's at high risk of having a recurrence of her hyperhemolytic syndrome. So ASH guidelines suggest to give immunosuppressive therapy, either IVIG, steroids, and or rituximab, if you want to prepare for a transfusion the patient at high risk of recurrence of hyperhemolytic syndrome. So how we prepared a patient? So we should avoid transfusion as much as possible and reduce the number of red cell units that we give to the least we can. We should consider giving steroids and or IVIG. Like I said, rituximab would prevent new alloantibody formation, And other potential useful drugs to use before the transfusion are daratumumab, which is an anti-CD38. So it targets the plasma cell that produce antibody. And bortezomib. Bortezomib is a drug that inhibits the plasma cell proteasome, and it causes the cellular death of the plasma cell, so no more antibody production. And you have to closely monitor the patient after the transfusion to make sure he doesn't develop hyperhemolytic syndrome, and if yes, you have to add quickly other treatment. So the patient received rituximab 2 doses, 2 weeks apart, also IVIG. She had her manual partial exchange transfusion the day before the surgery, a good IV hydration before and after the surgery. We also give 1 dose of tranexamic acid before the surgery to decrease the bleeding because it's a surgery that is at high risk of bleeding. And we want to decrease the risk that she needs a lot of blood product. And we closely monitored the patient for DHTR after the surgery. So the patient just lost 300 ml, so it's not a lot for a scoliosis repair surgery. She didn't need other blood product than the partial manual exchange before the surgery. And she did not present any delayed hemolytic transfusion reaction or hyperhemolytic syndrome. And she did not have any vaso-occlusive crisis or acute chest syndrome because she was well prepared before the surgery. Thank you.
Thank you so much, Dr. Arsenal, for that wonderful talk. We're going to hand it over to Ms. Fossua for her presentation, and then we'll do questions after both sessions.
Hello, everyone. Good afternoon. As she said, my name is Josephine Fossua. I was born with sickle cell anemia type SS, diagnosed when I was about 3 years old, and basically grew up in the hospital. So before transfusions came into my life, I would have multiple hospital stays. I don't remember getting transfused during those stays. A lot of fluids, a lot of antibiotics and other medications to kind of get me set back right and everything. When I first got introduced to transfusions, it was presented as a treatment, but after I was offered hydroxyurea. So I was about 15, 16 years old, still at Sick Kids, and I guess sickle cell got into a point where it's like we needed a more stabilized treatment to help me get through each day. And at that time, I was learning a lot too about myself and my diagnosis and what it is that I need to do to take care of myself. Unfortunately, for my mom, it was overwhelming and she didn't understand anything the doctors were saying. So being a young teen, trying to understand my life and the things that I'm going through on a medical level, I had to kind of perk up and try to understand what the doctors were saying. So I had to turn it and tell them, like, you have to tell me now and explain certain things to me so I understand what you guys are talking about, because my parents are not getting it. So I'm gonna have to be my primary caregiver in this situation. So when, I believe it was like Dr. Kirby and some other medical professionals who came together, we had a meeting and hydroxyurea was presented to me. Now for me, I go off feeling a lot, and it's mostly because like I just know my body. And with the understanding that I have developed my own research, that I've gone through the questions that I've asked throughout my life, I'm able to kind of tell what works for me and what probably won't work for me, right? And I've had my time to like ask other patients and families what treatment direction did they go in. But also I had full understanding that my situation is slightly different, if not immensely different, because I've gone through experiences like transplants and other medical issues that they haven't gone through. So for me, everything factors in. So hydroxyurea did not sound like a good treatment for me. And I remember just sitting there in the boardroom, just thinking about it, and kind of blacked out because I'm just like, it doesn't make sense. And then last minute, I think it was Dr. Kirby who said, oh wait, we could probably try transfusions. What about that? And I'm like, oh, okay, say more. So the goal was to get my sickle S levels as low as possible to reduce the crisis, because at that point I was in the hospital almost every other week, right? Missing school, missing life itself. So we needed to get my S levels down as low as possible. And if hydroxyurea was not sitting right with me, what was the other option? And it kind of just snapped, like a light went on when they said that, and they explained it a little bit more. Then I'm like, okay, well, we're gonna try that. So it started, the transfusions, first with just coming in every 4 to 5 weeks to get straight transfusions. I did my blood work, they matched my blood, got the products ready. I went to Princess Margaret, spent the day there, and got transfused with blood, went home, and did that routinely. Then things shifted over to Toronto General, where I was in the day unit getting transfusions. But then we started to see some inconsistencies in the treatment. So we decided that we're gonna do some depletion first, right? So transition from top-ups to depletion. So I started doing depletions where they'll take off manually blood from my body. So that was not easy because you're literally draining me. And I'm this small little thing that you're gonna drain me of blood before you put blood back into me, which was very hard also on my body, because if we didn't do it right and we didn't take our time, too many complications, one of which me passing out. So I had to learn how to at least eat or have food and prepare myself for that treatment. That didn't last too long, and we had to figure out, okay, how could we balance this out? Because one, my veins are not friendly to any technician or nurse. Doesn't care who you are, how long you've been in the business. My veins are out. When they say they're out. So I got a PICC line, right? Even then, when the PICC line, my blood was like, we're not coming out, this is too much. Like, you're pulling, no, right? And then we went over to portacaths. So I had a single lumen portacath to begin, and that started to work a little bit better. So draining the blood worked a little bit more consistently, but still we had issues with keeping me stabilized, right? Because it was still taking too much out of me. The process was just too unstable for me to stay alert, to get through and get fluids and then the blood to replace what was taken off. After a while, by then I transitioned over to I started at SickKids, but then I transitioned over to Toronto General, and we got, we figured out the treatment that was the method that was better for me. I had a rhythm. But then my doctor, I think it was maybe 5 years into me being at Toronto General, he came to me and said, have you ever heard of apheresis? Obviously, no, I haven't. I don't know what that is. So he explained what apheresis was and the technique and how to transfuse blood but also deplete blood. All right, and at that time too, I have gained a lot of iron. So I had iron overload, and I was doing treatment for that as well, which was not pleasant. My body did not like it. So yes, there are times where I didn't do it. But I still got through it. I'm standing here today, so obviously. So yeah, apheresis was a godsend because that allowed iron to be taken off without me having to do the iron chelation therapy. And then also, because it works simultaneously, taking off blood, like depleting, but also transfusing me at the same time and giving me vitamins in between it, it made the whole process less vigorous. And all I had to do was just lay back, and I didn't feel much different. I got tired, all right, a bit itchy, hot, weird flashes of heat, right? But that was probably just the vitamin D. I don't know. But yeah, so once we figured that out, I got what is it called, Benadryl, to help kind of stabilize that little anxiety that my body, the shock that my body was going through, which helped. And transfusions started to become a lot easier. And then I got the Vortex Portacath, which was a double lumen. And a lot of people, surprisingly, I'm like, I'm in the hospital, you guys gave it to me, but a lot of nurses and doctors did not recognize it. So every time I would come into the emergency room or come in to like randomly because like I'm sick from something else going on in my body, and I tell them, don't put an IV in me, don't waste your time, just access my Portacath, but it's a Vortex. And they're like, what is that? And I'm like, it's a double lumen. I thought you guys know this. But they don't. So like, I have to always advocate, and I have to always educate, right? So I have to keep up. And going through sickle cell, you know that we get a lot of pain meds, we get a lot of other medications. So my brain does not brain like everybody else, right? I have to do a lot to stay alert and stay on top of things just so I'm getting the correct treatment and I'm making the right decisions for me. Because like I said, from a very young age, I had to take that over. And making the decision to choose transfusions as a treatment option with the little education I have. And by the way, I've learned a lot with just your presentation. There's a lot I did not know, and I need a copy. Because I think that will honestly help too with reaching out to our community, our Black community, and getting them to donate if they understand the differences between our blood, right? And why it is that we need it. Because I did not know that, and I could have used that months ago. Yeah, so apheresis started to work, and knowing more helps me educate those who are caring for me. And as long as they have a listening and learning ear and heart, I'm able to learn from them as well. And we partner, so that way when things are not going well with my treatment, we can pivot and adjust. Like 2 months ago, we just found out that apheresis worked way too well, and now I'm low on iron. So we're playing catch up again. All right, so now they're adding iron to me, and we've stopped depletion for the moment, so that way, and added like iron transfusions as well after my treatment. So I'm currently going through that, and it's very interesting because iron looks like, yeah, I don't know how, it's like they got metal to turn into liquid and then they're putting that inside of you. It's interesting. But it's an adjustment, a weird one, but I'm getting through it. I've been tired a lot. I'm even tired today, and I have a lot going on. But yeah, so that's my experience with transfusions. I've gone through every single type of method that we could think of, and apheresis is where sometimes machines are our best friend because it works, it's working, and now we just have to, keep on the wave. I've never had any horrible reaction like the alloimmunization that you're talking about. I'm still learning about that, by the way. Yeah, I think everything for me, I've kept my same antibodies. If anything, the worst reaction I've had is fainting or like, yeah, fainting and getting dizzy after a transfusion. Usually because there's probably some other underlying issue, which is like either I'm underweight or I haven't eaten or I'm dehydrated, something of that sort, or something else is going on. But I've never had any major issues getting blood. Like, I'm B positive, and I feel like I've been very blessed to not have much setback when it comes to receiving blood. My body has been very accepting of it, hasn't reacted much at all. And yeah, so I've been pretty blessed with kind of straightforward. My body likes the apheresis enough to allow it to continue to work, and hopefully one day I won't need it at all, and my body is just like, oh, we get it now, so we're gonna correct the issue. In Jesus' name, amen. Thank you.
Thank you so much, Josephine, for that eye-opening and insightful talk. We now welcome questions from everyone for our two wonderful speakers.
Good afternoon, everybody. I just want to commend the young lady that just finished talking. And one of the reasons why I'm doing that is that I stayed a little bit over there, and one of the presenters was somebody with sickle cell disease, and was saying that I have to fight all the time and so on. But the way she presented here, she said she has to educate the nurses and doctors and so on. There's nothing wrong with doing that. My triage, and I'm triaging somebody, and they will tell me, Google told me I have appendicitis. I don't have to argue with you. Just listen to you for a moment. If you are comfortable in what you are doing, you'll be able to listen to young people going through this from birth. And you can only imagine what we take for granted, you know, because there are times they're just planning to go to the mall, you know, the crisis will hit them and they have to go to the hospital. So I'm learning a lot from people that I've never met and I'm meeting today, and also so many things that have gone into this presentation. So we're very, very grateful.
Thank you for that.
Dr. Askin, thank you so much for that very clear presentation. I learned quite a bit. I just wonder, do you have any information on the role of microRNAs in the pathogenesis of alloimmunization?
What, sorry?
MicroRNAs.
MicroRNA. Oh, and I don't have a lot of information about microRNA. Do you? Sorry.
Well,
It would be my pleasure to.
I'm only asking because you see, I'm the editor-in-chief of Hemoglobin.
Yes.
And I've been getting some manuscripts on microRNA in alloimmunization, and I'm looking for reviewers.
Ah. I would be happy to learn about it, but I didn't see a lot of that in my my readings. But potentially I can.
So if you do any good, you have to.
Sorry.
Thank you. Yes. Please go ahead. Hey.
I have a question about alloantibodies. So that's one of the challenges in Ontario is information about alloantibodies is not well shared between different sites yet. It sounds like Canadian Blood Services is going to be doing some work in that area, which is very exciting. But I wonder in Quebec, how is that information shared? What is it between the sites?
Oh, really good question. So in Quebec, we are very, very extremely lucky because all the different hospitals in the Quebec are related to each other because they have the same LIS at the blood bank. So there is a summary of all the antibodies and the exposed red blood cells and all the products. So when you go to it's called trace line. So if you go to this LIS, you will see what the patient received in all the hospitals in Quebec, and if he is known for an antibody, you will see it. So it's really, really helpful because as you saw, 80% of alloantibodies become undetectable at some point in life. So if you do the antibody screen, it will be negative. So it's very good to know, to have access to all this information. So we are really lucky. It's been since 1998 that we have that. So yeah, very safe for the patient. I did my fellowship in Toronto, and I remember that the technologist had to call, so the nurse had to ask to the patient where he went, in different hospitals, and after that the blood bank was calling all the other blood bank to see if the patient was known for transfusion and antibodies. So that is, I think it's less safe for the patient, because you can miss something, and maybe there is an antibody, you will give positive blood for that one, and it will do the delayed hemolytic transfusion reaction.
So we have work to do. Any further questions? Absolutely. Yeah.
Wanted to add one thing. Like I said, I've learned a lot from her presentation, right? And I'm gonna hit you back up on that. But one thing that was a game changer for me, and you also mentioned it too and elaborated that, don't jump quickly to transfuse, right? So for me, when I was hospitalized and I had like attending physicians look after me, or nurses, quickly look at my hemoglobin and want to transfuse me, the thing I was lucky to learn from my doctor, from Dr. Pendergrass, was my rectic count. So that's something that kind of was a game changer to me. So the reason why I haven't had like super bad reactions or anything is because he told me about my rectic count, and every time I'll do blood work and I'm in the hospital, I'll check my blood work. And so when they came to me and said they wanted to transfuse, I'm like, did you talk to Dr. Pendergrass or Dr. Ward first? Because I'm looking at my chart right now and it says this. I wouldn't recommend. So talk to them first and then come back to me, right? So, because the doctor that would look after me is not necessarily a hematologist, right? So they're not 100% educated on exactly how to treat me while I'm in there. So that's something that really stuck with me, and I was able to protect myself from not having complications when it came to actually receiving blood.
How do we equip our warriors to be able to speak up like Josephine? Because it's not that warriors don't try. I've even shared, hey, they'll speak up, and to have them speak up and get back to me and say, I spoke up, and then they're treating me worse. So, yes, they should speak up, but how do we, equip them with the words and phrases? I think it's really good to be educated about your own sickle cell. Like, what does sickle cell look like for you? So that you're able to speak to those parts. So I just put that out in the air that Josephine is an excellent example. We need more of this. How do we get warriors with that? As they're going through their pediatric journey, as they get to adult, and especially through their pediatric journey, so when they get to adults and they're controlling care, that they're already equipped with that and feel more confident on that transition. So, thanks.
I just had a question as well. I think with your presentation, you talked about looking for sort of these hemolytic reactions. Are all folks in Quebec, I guess, flagged if they have sickle cell disease and need to have a transfusion? To Josephine's point, like, how do we ensure that no one's falling through the gap?
So at Saint Justine Hospital, it's a pediatric hospital. So we have a rule that if a sickle cell patient, if a doctor wants to transfuse a patient with sickle cell, he needs to call the hematologist. He cannot order blood transfusion. He has to discuss it with the hematologist on call. And for specific patients that have rare blood, so sometimes patients develop antibodies against antigens that almost everybody has, but a couple of person in the whole province doesn't have, and they will react to all bloods except some rare blood. So that these patients, they are flagged in the blood bank LIS, and if the blood bank receive an order for transfusion, they will ask just to me or like one of my colleagues who is specialized in the sickle cell. So if it's okay, it's not all the hematologists that can order blood for these patients. It's just like specific person that are experts in that. So we have this rule just to make the transfusion as safe as possible for the patients.
Dr. Arsenault, I have a question for you. We've really highlighted the importance of avoiding red blood cell transfusions in patients who have had hyperhemolysis. Is it feasible then to proceed with curative therapies like stem cell transplant, where we know that conditioning will require often regular red blood cell transfusions?
In fact, it's really tricky. We had one patient at St. Justin Hospital that had a severe hyperhemolytic syndrome a couple of years ago that had an indication to proceed with stem cell transplant. And so we went through it. We prepared, we did like a desensitization preparation protocol, and we gave a couple of immunomodulatory therapies, including rituximab, daratumumab, bortezomib. We gave also corticosteroids, IVIG, and also we did plasmapheresis to remove lots of antibodies 5 days in a row. And after that, we proceeded with the bone marrow transplant. And the patient needed 7 transfusion, red blood cell transfusion, and he didn't react it. He tolerated well because we had like we did an important immunomodulatory therapy, and the chimerism after the bone marrow was 100%. So he did not have also because we were afraid of pure red cell aplasia. So it's when the patient, because of the antibody, it reacts against the stem cells that are given, and it prevents the stem cells to proliferate and do the erythropoiesis, but he didn't present that too. So now he is well, he is cured, and it went well, yeah. So it's feasible, but with lots of preparation.
Thank you.
Honestly, resources like SCAGO is very, very helpful. Like I haven't been a fan of support groups, but I've always tried, right? And I've asked questions. I've gotten involved with the hospital itself. And one of my biggest sources is my doctor, right? Because, well, there was a transition from the doctor I had when I came over to Toronto General, and she ended up retiring, right? So with her, I didn't get much from her, and honestly, I had to work really, really hard to get, information from her, or to even, prepare myself for times where the clinic was closed. But when she left, I think it was like a year and a half in, she retired, and I was given over to Dr. Pendergrass. He is a study ward. Like, he works, and if anybody I could say really fights to understand sickle cell, it's him. So he became my biggest source. He told me about the work that he does in the lab. He helped me understand different parts of my blood makeup, and what transfusions are doing for me, what it could do, what medications would do. Like, he sits and discusses things with me. I have a question, I'm able to ask him, and he'll answer it. He'll give me printouts. He will direct me to the right websites and stuff to read and get the information that I need. So I think being able to allow your patient to form a good, healthy relationship with you as a physician allows them to open up and ask questions. And then receiving the right information from you gives them the confidence to learn about themselves, right? And not just sit back and be like, well, you got it, I'm just gonna do whatever you say. But no, now they're gonna be like, okay, I know this now because you gave me this information, I wanna know more. And that's basically what I did. I went to him and I was able to ask those questions. And I don't take well to new people, I have to suss you out first, right? I have to be like, okay, I'm not gonna say much, let me just see what you say. But he came and quickly showed me that I'm not just a number, I'm not just a health card number. I am a patient, I am a person, I am someone. He wants to befriend and understand. He wants to know my life. He wants to know what it is that I need in order for him to help me as best as he can. So we've always had a partnership, and that's important for every patient, is to feel like they could have a partnership and be able to communicate and understand themselves on a different level where, you know, they're not gonna have to go to school for 12 years just to learn how to be a doctor in a specific field, but they could take their life experiences and rift off of you who went to school and studied this and know exactly what direction they need to go in.
I think that deserves a round of applause. Any further questions? I think we have time for maybe one more. Okay. All right. Thank you so much, everyone, for your attention and your involvement during the sessions. And thank you again to our wonderful speakers for enlightening us today.